Hello, my name is Roger Henderson. I'm a GP and I also co-host the GP Notebook study groups. Welcome to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now, in this episode, we'll be discussing cirrhosis, a condition that's as fascinating as it is dangerous. And in fact, this topic has been suggested by one of our podcast listeners. So many thanks for getting in touch. It's a great idea. Now, cirrhosis isn't just a disease of the liver. It's a systemic condition that affects nearly every organ, alters blood flow, changes hormone metabolism, and can dramatically shorten life if left unchecked. So let's start with the basics. Cirrhosis represents the final stage of chronic liver injury. And what happens is this. The liver responds to repeated or sustained damage by forming scar tissue, or fibrosis, and regenerative nodules. And over time, this permanently distorts the liver's architecture. Now, initially, the liver can compensate. It's a remarkably resilient organ. And that's why so many people live with cirrhosis for years without any obvious symptoms. But eventually, the fibrosis overwhelms the liver's capacity to function, and patients then progress to what we call decompensated cirrhosis, which carries a much worse prognosis. Now, the causes of cirrhosis are numerous, and geography plays a big role here. In high-income countries, the leading causes are chronic hepatitis C, alcoholic-related liver disease, and non-alcoholic steatohepatitis, or NASH. In lower income regions, hepatitis B is a major contributor. Other important causes include autoimmune hepatitis, cholestatic diseases like primary biliary cholangitis and primary sclerosing cholangitis, metabolic conditions such as hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency, and vascular disorders, including Budd-Chiari syndrome. But sometimes we can't identify any cause, and that's classified as cryptogenic cirrhosis. Now, to further understand cirrhosis fully, we need to look under the microscope. And at the cellular level, hepatic stellate cells are key players here. In healthier livers, these cells store vitamin A and remain quiescent. But chronic inflammation or injury activates them, transforming them into collagen-producing myofibroblasts, and this drives fibrosis. At the same time, sinusoidal endothelial cells lose their fenestrations, impairing nutrient and oxygen exchange, whilst Kupffer cells, the liver's resident macrophages, release inflammatory mediators and so perpetuate injury. Damaged hepatocytes themselves contribute to this cycle by releasing reactive oxygen species and cytokines, further promoting stellate cell activation. So it's a vicious cycle. Injury leads to fibrosis, which leads to more injury. Now, one of the most important consequences of cirrhosis is portal hypertension. As fibrosis narrows the sinusoids, resistance to blood flow increases. Normally, hepatic stellate cells and endothelial cells regulate blood flow using a balance between nitric oxide, which relaxes vessels, and endothelin, which constricts them. But in cirrhosis, this balance is lost. Intrahepatic vessels constrict, while systemic and splanchnic vessels dilate due to excess nitric oxide, and this creates a hyperdynamic circulatory state with sodium and water retention, ascites, and collateral vessel formation, including esophageal and gastric varices, which can be life-threatening if they rupture. Now, as I said at the start, cirrhosis isn't just a disease of the liver. It affects nearly every organ system. Hematologically, patients can develop anemia due to nutritional deficiencies or hemolysis, and thrombocytopenia often arises from hypersplenism. Kidneys can be affected by hepatorenal syndrome, which is not primary kidney injury, but results from systemic vasodilation and decreased renal perfusion. Pulmonary complications include hepatopulmonary syndrome, where intrapulmonary vascular dilations cause hypoxemia, and portopulmonary hypertension, which strains the right heart. Endocrine changes are also notable. Altered sex hormone metabolism can lead to hypogonadism, gynecomastia, menstrual irregularities, and infertility. Dermatological signs like spider angiomas, palmar erythema, jaundice, and nail changes often reflect chronic liver dysfunction, and neurologically, hepatic encephalopathy can manifest subtly as confusion or sleep disturbances, or much more dramatically with asterixis, better known as liver flap, where there are arrhythmic flapping movements of the hands, as well as fetor hepaticus, a musty, sweet, or rotten egg-like smell on the breath. Now, when we turn to evaluating a patient with cirrhosis, laboratory testing is a cornerstone here. Routine blood tests often give us early clues, even before patients develop overt symptoms. AST and ALT are frequently mildly elevated, and interestingly, in advanced cirrhosis, AST often exceeds ALT, resulting in a reversal of the typical AST to ALT ratio, a pattern particularly seen in alcohol-related disease. The liver's synthetic function is reflected in albumin levels and prothrombin time. So low albumin indicates reduced protein synthesis, whilst a prolonged prothrombin time suggests impaired clotting factor production, and both are considered to be reliable markers of hepatic functional reserve. These hematological changes, like thrombocytopenia, often develop early and may signal portal hypertension as platelets are sequestered in an enlarged spleen. There may be anemia resulting from multiple mechanisms, including nutritional deficiencies, chronic blood loss and varices, or hemolysis, such as the spur cell anemia, so often seen in severe alcoholic cirrhosis. Now, targeted tests can help us identify the etiology of cirrhosis if present. Viral hepatitis testing includes serologies and PCR for HBV, HCV, and HDV. Autoimmune markers such as ANA, anti-smooth muscle antibody, and serum IgG are assessed for autoimmune hepatitis, whilst antimitochondrial antibodies can indicate primary biliary cholangitis. For patients at risk of hepatocellular carcinoma, serum alpha-fetoprotein may also be monitored, although imaging remains the mainstay for diagnosis here. Now, overall, blood tests not only assess liver injury and function, but they also provide clues about the underlying causes, complications, and prognosis, so they're essential for staging the disease and for guiding therapy. Now, I mentioned imaging there, and this plays a critical complementary role in the diagnosis and management of cirrhosis. Ultrasound is typically the first line here because it's inexpensive, non-invasive, and widely available. So on ultrasound, a cirrhotic liver often appears nodular and heterogeneous, and the caudate to right lobe ratio may be increased, and spleen enlargement and collateral vessels may also be visible. Doppler ultrasonography evaluates the patency of the portal, hepatic, and mesenteric veins, and this can detect portal vein thrombosis, a complication of advanced cirrhotic disease. And ultrasound is also routinely used for hepatocellular carcinoma surveillance in cirrhotic patients, usually every 6 months or so. CT and MRI scans provide much more detailed anatomic and functional information. CT is excellent for detecting tumours, vascular abnormalities and complications like ascites, whilst MRI offers superior soft tissue contrast, and so it makes it particularly useful for characterising liver lesions and identifying iron or fat deposition. Magnetic resonance cholangiography, or MRC, can non-invasively visualize the biliary tree, which is helpful in cholestatic cirrhosis or suspected biliary obstruction. Now, another increasingly used tool here is transient elastography, often referred as fibroscan. And this technique uses high-frequency sound waves to measure the stiffness of the liver, which correlates to the degree of fibrosis. It's non-invasive, it's quick, and it's increasingly used to monitor the progression of disease or its response to therapy. But unfortunately, it does have limitations, particularly in patients with obesity, ascites, or acute inflammation. Now, finally, whilst imaging does provide strong evidence, liver biopsy remains the gold standard here for confirming cirrhosis and for grading its fibrosis and inflammation. Now, even though it carries a small risk of sampling error, biopsy can definitively identify the pattern of fibrosis, the presence of nodules, and even sometimes the underlying etiology, guiding both prognosis and therapy. Management of cirrhosis focuses on three main goals: preventing further injury, treating complications, and addressing the underlying cause. So lifestyle interventions are fundamental here, such as abstaining from alcohol, vaccinations against hepatitis, and weight management in NASH, all being essential. Pharmacologic therapy is often disease-specific, so antivirals for hepatitis, immunosuppressants for autoimmune hepatitis, ursodeoxycholic acid for cholestatic disease, and phlebotomy or chelation for metabolic disorders. Now, once complications develop, we then intervene with things like diuretics, paracentesis, lactulose, non-selective beta blockers, and endoscopic therapy if varices are present. The prognosis, as you might suggest, depends heavily on the disease stage. Tools like the Child-Turcotte-Pugh and MELD scores help to stratify risk and guide the timing of any transplant, but liver transplantation often ultimately remains the only definitive therapy for end-stage cirrhosis, offering excellent survival outcomes, although recurrence of the underlying disease and long-term immunosuppression are ongoing considerations here. Now, finally, I think we must highlight hepatocellular cancer. Cirrhosis, especially when caused by viral hepatitis, is the most important risk factor for this. So routine surveillance with abdominal ultrasound every 6 months is essential for early detection when curative therapy is possible. So what's my takeaway here? Well, cirrhosis isn't just a liver disease. It's a systemic condition with complex pathophysiology, widespread complications, and a high risk of both morbidity and mortality. Early recognition, management of any complications, treatment of the underlying cause, and timely referral for transplantation are all the keys here to improving patient outcomes. So that's a quick overview of this complex condition, but I do hope you found the podcast helpful. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you've any questions, comments, or ideas for future podcasts, as in this case. We really do love to hear from you. You can also visit us at GPnotebook.com to register for our virtual GP Notebook study groups that occur all year round. And don't forget to download our free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you so much for listening, and goodbye.